Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health. Hello, I'm Mark Houston, and welcome to a special rerun of Doc Talk. Today, we're revisiting episode 30, Time for TAVR with Dr. Joseph Tuma, just in time for Heart Valve Disease Awareness Day. TAVR, or Transcatheter Aortic Valve Replacement, is a groundbreaking procedure for those with aortic valve disease. If you or someone you love is at risk, this episode is a must-listen. Now, let's dive in. Here's episode 30, Time for TAVR with Dr. Joseph Tuma. Hello again, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me today is Dr. Joseph Tuma from Monument Health. And I was really excited just to read your short bio here, Doctor, because there are so many great words in it. You are what's called an interventional cardiologist, correct?
That's correct.
And you are, according to the website from Monument, an expert in the field of coronary and structural interventional cardiology and peripheral vascular disease.
Yes. Yep.
When you got that first title, that had to feel good. Didn't it? I mean, that's a good thing to have.
Yeah, that was a series of training steps to get all those titles. Yeah, right.
Now, are you? Are you from Nebraska originally?
Mm-hmm. Yeah, I grew up in Rushville, just 2 hours south of here.
So you're very familiar with the area then.
Oh, yeah.
Yeah.
Yep.
Did you spend any time here growing up or come up to the hills and hang out?
Oh, yeah. We would come up every summer for a vacation and, all of our orthodontist appointments and doctor appointments and everything are in Rapid City. So, yeah. Oh, yeah. My whole life, we made frequent trips to the Black Hills.
So is that... Why when you were growing up and you were a kid and you were thinking about what you were going to be, was this on your radar the whole time in a way?
So medicine was.
Okay.
It's interesting when I look back, I wrote a paper in 8th grade, a career day paper, 7th grade, 8th grade. And even then I kind of knew I wanted to be a physician. And so when I got to the point of selecting colleges, there was a program at Shattered State called the Rural Health Opportunities Program, which basically you complete 3 years of undergraduate and then you get accepted into the medical school at University of Nebraska.
Oh, I see.
So it worked perfect for me,
yeah.
And the setup was perfect, and really that was my gateway into the world of medicine. And but yeah, no, I since I was a little kid, that's kind of all I wanted to do, and just kind of stuck with it. So here I am.
What led you to what is arguably the most important organ in the body then?
Yeah, so originally when I was in medical school, I thought I was going to be an orthopedic surgeon.
Okay.
And I had actually matched in an orthopedic surgery residency, but kind of, after I got into it a little bit more, I was just fascinated by the complexity of the heart and decided that would be more my speed. And interventional cardiology in particular, one of the things I think that's most gratifying is that people come very sick. They come, they're having a heart attack. They're obviously not going to do well if you don't fix it. And with a little tiny puncture and a catheter, and you can put a stent in, and in an hour they're fixed. And so, it's just an immediate gratification type of thing, and that's exciting. And there's an adrenaline, rush that goes with that. And but the ability to make such a big difference in such a short amount of time, I think, was a lot of what drew me to that.
So this is you're dealing with people that are in pretty serious condition then with their heart.
Right.
You're kind of on the more serious end of this then.
Yeah, a lot of when they present acutely,
Mm-hmm.
when they present having a heart attack or they, suddenly block off an artery in the leg or something, it's kind of time is of the essence, and you have to very quickly restore blood flow. On the other hand, there are a lot of things we treat very sort of conservatively, I guess I would say, where we decide to treat with medications or lifestyle changes and that type of thing. So it's really the whole spectrum, from routine clinic visits all the way to somebody who's really in big trouble and needs to be fixed right away.
Or somebody that might need what we're about to talk about here on this podcast, which is it's fascinating. It seems simple too, in a way, if you watch this at all, but it's called TAVR. And
Right.
can you explain a little bit about of that, Dr. Tuma?
Sure. TAVR stands for Transcatheter Aortic Valve Replacement.
I wasn't going to say it.
And that's actually a really good way of putting it. It is sort of simple. It's the procedure itself and the concept is simple. Getting it down to a procedure that can be done consistently and with a minimal complication rate has taken a long time. But yeah, we're there, and I mean it's been available in the U.S. commercially at least since around 2012.
Okay.
We started doing it at Monument in December of 2014.
Now, who would be a candidate for a procedure like this?
So it's the TAVR procedure specifically for people with severe symptomatic narrowing of the aortic valve.
And that's the one that pushes the blood out or in?
Out.
Out, okay.
Yep. All the blood that goes to the body that's pumped out from the heart goes through the aortic valve.
Okay.
So as that valve gets more and more narrow, you don't as effectively pump blood to the body, and also puts a tremendous amount of strain on the heart. The heart has to work harder to push blood out. Either one of those can cause problems. And so once symptoms start to develop, it's time to fix the valve. And it started out originally in the early part of the procedure, 2013-14, where only people that were not surgical candidates were candidates for the transcatheter valve procedure. And then as it's evolved, as the devices have iterated, it's now really approved for anybody. I mean, low risk, intermediate risk, high risk. And the way we do it is we assess every single patient as part of what we call our heart team, which is myself, our imaging cardiologist, and then our cardiac surgeon, along with our advanced practice providers. So every single patient is evaluated that way. There still are a number of patients where surgery is a better option for a variety of reasons. If the valve won't work, or the anatomy doesn't allow us to get the valve in, or there's so much calcium on the valve that we just have to go in and take it out. Mm-hmm. So surgery is still an option in a number of people, and that's what our heart team really sits down and decides.
So is this something that is a better option than a valve replacement?
So it's technically it is a valve replacement.
Okay.
So what we're doing is we basically put a tiny little guide wire across the narrowed valve. And with the transcatheter valve, you're putting a new valve in, and basically what it does is push the old valve out of the way.
It's amazing.
So we put it in, and there's two different styles of valve. One is balloon expandable. So you put it across the old valve, very rapidly inflate a balloon, and it deploys the new valve. The other one is self-expanding. It's made of a nickel titanium alloy, which has the properties of a slinky.
Right.
And so what we do is we put it in place and then pull a catheter back, and the valve flowers out, but again, pushes the old valve out of the way. And so it's a valve replacement. It's not necessarily better than surgery. Most of the studies would sort of suggest it's as good as surgery. And so the benefit is you get the benefit of a new valve without having to go through open heart surgery.
Well, and it seems, again, and I would encourage anybody to search for a video of this being done. Right. I would recommend the animated version of it, though, unless if you got a weak stomach, which is the one that I looked at. But it's a very... It seems, how long does it take to do this once they're prepped and ready?
Yeah, once they're prepped and ready, we put a tremendous amount of time into planning. Mm-hmm. And so everybody has what we call a TAVR CT angiogram, a CAT scan of the chest, abdomen, and pelvis. And so going into the case, before every TAVR day, we usually do them in 2 or 3 a day, we sit down with everybody, with anesthesia, with surgery, with our cath lab staff, our surgery staff, and come up with a case plan on everybody. So with that, we say we're going to use, what route we're going to put it in, what size of valve, any anticipated problems based on the imaging. So we have a very detailed case plan going in, and then when we start the procedure, we basically execute mm-hmm. the plan. And so on average, our average case time is about 60, 70 minutes.
Oh, wow.
Not. Yeah.
I mean, compared to how that used to be, there've been 500 of these done here in Rapid City.
Right.
You have done all 500 of them.
Right.
Correct? Right. So before that, you obviously were doing something else. So you've seen the change of this happen.
Absolutely.
And I mean, to you, are you kind of amazed at the procedure and the quickness of it and the recovery rate with it?
Oh, it's I mean, even after 500, and I, with our surgical team, I've been involved in all of them here at Monument. And as you get more comfortable with the procedure, as the devices get better, I mean, even today, it's still sometimes astonishing to go see those people the next day, and they're up walking around and in their street clothes and ready to go home. So,
that's amazing.
Yeah.
Well, speaking of that, what is kind of the recovery time then for something like this?
So after the procedure, typically what we'll do is watch people in the postoperative, the PACU, the postoperative or post-anesthesia care unit for a couple of hours. And then they go to the step-down unit. We don't often send people to the ICU anymore. They have bed rest for 6 to 7 hours to let the puncture site in the leg heal. And then they can get up and start moving around. And the majority of the people are awake and starting to, let the anesthesia wear off in the room. As soon as we're done with the procedure, they start to wake them up. And about 75% of our people go home the next day. So
that's amazing.
Basically come in, get it done, and go home the next day. Our restrictions really are lifting restriction. Don't lift anything over 10 pounds for a week or so. Kind of have to take it easy just to let the puncture site heal, but that's really about it for restrictions. So
when you have an issue with that valve, can you feel it? Is it something that it's noticeable?
Yeah, what's interesting about the aortic valve is it has a pretty predictable series of symptoms.
Okay.
And typically starts out with shortness of breath with exertion, where people just start to feel like they can't do what they used to do. And then the next thing that usually happens is they can start to get dizzy spells, lightheadedness, which is sort of, starts to become alarming. It can even advance to a point where they pass out. They can start to get chest pain, chest pressure, chest tightness, particularly with exertion. Mm-hmm. And then as the disease progresses, the heart will eventually start to fail. And so the end of the road with aortic stenosis or narrowing of the aortic valve is heart failure, where you start to fill up with fluid, the lungs fill up with fluid. The shortness of breath with exertion sometimes is hard to sort that out. A lot of times people just say, oh, I'm getting older.
Right.
And
not working out as much.
And out of shape. But really the murmur that the narrowed valve causes is very distinct.
Okay.
And it's very easy to hear. So a lot of our referring providers pick up on that right away, and they do a great job of, the patient's telling them they have these symptoms, they listen to the heart, and they say, wait a minute, you have a heart murmur, we need to get you in to see the heart team. And so and it all starts with an echo. The heart ultrasound, 99 out of 100 times, that's how we pick it up. And then we just kind of take it from there.
So I can't imagine after that procedure's done, they must also be able to feel so much better when that valve is open and working.
Yeah, and that's the other thing with TAVR that's so gratifying is people come in, they aren't feeling well, they're not doing the things they used to do, they're pretty disabled. And because they don't have to recover from an open heart surgery, the next day they're up running around and they feel so much better. And
you got to calm them down a little.
Hold on. Yeah. And it's interesting too, because some have been, we've had a few people who really are, moved to tears because they feel so much better. And they felt like they weren't going to make it another 6 months, or I'm not going to see my granddaughter graduate. Those are all stories I've heard. And the next day they're like, man,
this is great.
This is great.
Well, so that must be. This procedure is it specialized enough to where you have to go to bigger cities to have it done, and having it here in Rapid City, does that? That's a big deal for our community, then, isn't it?
It is, yeah. And I sort of anticipated that this was going to become a big procedure way back. And I will say the administration, this is to get this up and running takes a tremendous amount of administrative support. It's expensive. It requires a dedicated team. And essentially our TAVR cases, the entire OR team, the heart team is in the room, the cardiology team is in the room, anesthesia is in the room. We still to this day have 15 or 20 people in the room for every single case.
Oh, wow.
So it takes a lot of resources, but to be able to offer it here is a tremendous advantage because, before we started, the only places that we were kind of right in line with Sioux Falls. But, people would have to go to Denver, or Mayo Clinic, or Minneapolis, and the people with narrowed valve, and they may have transportation issues, and it's not so easy to get to Minneapolis to get a valve done.
Boy, no kidding.
So yeah, I was very adamant that we offer the procedure here, and we luckily got in the business early on. So.
Well, it has to be exciting to be in any sort of field that deals with the heart. The advancements that have been made over the decades just seem to be almost too fast, right? With what you guys can accomplish. Do you see? What do you see in the future for this, and what do you think ultimately? What would you love to see with something like this or a procedure like this?
Yeah, it's you're right. It is almost too fast, because
well, I mean that's great though. We don't
need
to make everyone aware that yes, that's a very positive thing.
It's hard to keep up, and cardiology has it advances so fast, that as fellows come out of training, we're now sort of super specialized, where people will come out of training and they just do structural heart disease, or they just do interventions on the coronary arteries, or they just do heart rhythm procedures. They don't really do other cardiology procedures because it's so specialized. And in the world of structural heart disease in particular, it's advancing at an unbelievable pace. I think the clinical trials will be a part of one of the clinical trials it's coming up there. It's actually one of 10 centers in the U.S. Will be one of them that's evaluating the TAVR procedure in moderate narrowing of the valve in patients with symptoms. So there's no indication for that now, but the data suggests that they do just about as poorly if you don't treat the valve as somebody with severe narrowing of the valve. And
so getting to it quicker then is just light years better. Obviously.
Better for the patient. The survival, if at least according to the data we have, is probably going to be better. We assume that's going to be the case.
Right.
There's studies out there that are looking at people without symptoms that have a severely narrowed valve and fixing those as well. And that's just the aortic valve. Mm-hmm. The field in the mitral valve space is advancing at an unbelievable pace. There's something like 30 or 40 devices out there that are being studied and developed, and the tricuspid valve has devices that are being developed, and yeah, it's unbelievable. Yeah.
Do you let's talk to some of these kids that may be considering going into a field like this. It sounds like the opportunities there are going to be fantastic for the new changes that are happening and the new discoveries that are being made. And, maybe somebody like you wanted to, be orthopedic. You're like, wait a minute. How much cooler is it to work on somebody's heart, right? Like you said, it has to be so gratifying because I think heart disease is still the number one killer of people in the world.
Right, in the U.S. in particular.
Yeah, exactly. Yeah. And so that has to be just a fulfilling line of work to do, to see what you're doing make such a difference.
Yeah, I always say, it's I cannot see myself doing anything else.
Yeah.
I love what I do, and I wouldn't change a thing. It's one of those things that you kind of gravitate towards, and the structural heart thing is something that I kind of evolved into even after I started my practice here in Rapid City. But to the young people out there, medical school is a lot of work. There's cost associated with it. But, if it's something you're passionate about, there's nothing better than having a job that you can't wait to get to every day.
Now, are you a doctor that uses playlists when you're working on people? Do you? Do you have a list you would like to share with us, Dr. Tuma? What do you like to listen to when you're inside somebody's heart?
So the funniest part about me is that everybody I work with knows I have two rules.
Okay.
No country music and no Christmas music.
All right. I'm with you on the Christmas music parts. All right. It's funny because the doctors that we've asked this question to, almost all of them say no country music. Yeah. You're from Nebraska.
I know.
What happened to you?
I think I was inundated with it when I was in Nebraska, so it ruined me.
That could be it.
But my playlist is a lot of, believe it or not, a lot of 90s rap. is.
I can respect that.
That's what I listen to.
Yeah,
so,
absolutely.
Snoop Dogg and Tupac.
Yeah. Are you going to a show then?
I'm not. No, I'm not.
All right. Well, Dr. Tuma, thank you so much for talking with us about TAVR. And I think that'll answer a lot of people's questions. And, when they listen to this and maybe if they experience that or if they know people that are experiencing this, we have here in Rapid City at Monument specifically just a wonderful, heart institute and place for people to come get the answers and help they need.
Yeah, absolutely. Our whole team is phenomenal, all the way from, our nursing staff, our imaging cardiologists and general cardiologists are top-notch, on through the interventionalists and the cath lab staff. Our surgical team is also fantastic. I mean, with TAVR and some of our surgical data, we have outcomes that are comparable to anybody in the country.
Excellent.
And so to offer that, right here at home is great.
It's very comforting, yes. So again, thank you very much, Dr. Tuma, for talking with us.
Absolutely.